Welcome everyone to today's webinar, Keeping ORs Open and Viable Amid an Anesthesia Provider Shortage. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation and have time at the end of an hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble at all with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. So with that, I'm pleased to welcome today's speakers. We've got Jeff Peters is the founder and chairman of Surgical Directions. We're also pleased to be joined by Dr. Jason Klopotowski, who is the department chair of anesthesiology at Baptist Health Fort Smith and a physician consultant with Surgical Directions. Jeff and Dr. Klopotowski, thank you so much for being here today. Jeff, I'm now happy to turn the floor over to you.
Thanks. I'm Jeff Peters, and what Jason and I are going to talk about is this crisis in anesthesia that's affecting anesthesia providers, hospitals, and ASCs. And some of our thoughts are based upon helping about 500 anesthesia groups and hospitals strengthen their relationship. And the problem with anesthesia obviously is affecting a lot of organizations, and up on the slide is one that I'm sure a lot of people have read about over the past couple of months. It's a hospital outside of Chicago that had a private anesthesia group. For lots of reasons, Advocate Healthcare decided they wanted to transition to a national anesthesia provider. The national provider took over, and on the day that they took over, they did not have enough anesthesia providers to cover their ORs. They had to cancel all their surgeries for a number of weeks, and they lost their level 2 trauma status. So this is a little bit dramatic, but it certainly talks about that there's a real shortage of anesthesia providers, and it's difficult for anesthesia to be covered in all locations. So in order to sort of get the discussion going, and again, we're looking forward to the questions and answers, well, we thought we'd talk a little bit about some of the causes and drivers of this crisis, changes going on in the acceleration in both physician and CRNA compensation, how the healthcare delivery system is really changing what hospitals and ASCs expect for anesthesia. And then what we'll try to do is to talk about the benefits and some of the challenges of different models for providing anesthesia care. And with that, I'm going to turn it over to Jason.
Thanks, Jeff. This is Jason Klopotowski. As introduced, clinically active anesthesiologist, as well as a leader of surgical services and anesthesia in various parts of the country. We really want to take this time to explain the major driving factors we see creating this crisis in anesthesia. Over the last couple of years, we increasingly hear the following phone call from administration, or question on a phone call from administration is, you know, I have really good clinicians in my anesthesia department. For years, they supplied good, safe anesthesia, but now all of a sudden, I'm getting calls about my anesthesia department being an issue in my ORs of delivering care and being available to add on cases or grow service lines. And it's perplexing to me because that's never been a problem. And we increasingly are hearing that, not anything about patient care or safety, but about the logistics and staffing of the OR with anesthesia providers. So we really wanted to drive home and talk about what we see as the key drivers of this crisis. After that, we would like to kind of discuss our strategies and view from 30,000 feet as far as how we're managing to continue to provide anesthesia services to drive surgeries at different hospitals around the country. So with that, we'll move on to the next slide. We really see four major disruptions causing this crisis in anesthesia. And we think we're seeing a supply issue, a demand issue. There's been changes in reimbursement and also changes in marketplace regulations that are all contributing to the problems we're seeing as far as staffing anesthesia services for healthcare systems and hospitals. First, we'll talk about supply. I don't think anybody is surprised that even before COVID, there was probably and likely going to be and predicted to be a shortage of anesthesia providers within the country. The rate at which we're producing residents and CRNAs was not keeping up with the demand for surgical services. The Association of American Medical Colleges predicted a shortfall of around 13,000 anesthesiologists by 2033. That was pre-COVID. Unemployment for anesthesiologists and both CRNAs is less than 1% at this time. And then really the straw that broke the camel's back as we see it is COVID. Anecdotally, there's been stories of somewhere between 3 and possibly as high as 5% of the anesthesia workforce has decided to retire, decided to change jobs, decided to decrease their FTE. And this 3% decrease across a system that was already strained really was the straw that broke the camel's back. And almost everywhere in the country, urban, suburban, rural, large city, small city, almost everywhere we go, we are seeing the strains that anesthesia is putting on surgical services. On top of all this, we're in between a transition from a master's degree for CRNAs to a DNP. As these institutions switch to the more advanced degree, we are seeing a shortage of the supply chain of CRNAs coming out of training during these years. So it's only adding to the already short supply we have of anesthesia providers in the country. So even before COVID, we were short. COVID did a number on us, and we're even shorter than what was predicted. We don't see the supply coming back to normal for years to come. Talked about supply. There's also an increase in demand for surgical services and anesthetizing locations. During COVID, there was a lull. We are coming back and catching up and resuming normal life. And what we're seeing, because of our aging population, increase in chronic disease of this aging population, we're seeing just basic surgical services in your hospitals increasing. We're also seeing an increase driven by the government and CMS to take more surgeries into outpatient centers. And while this is adding to the number of anesthetizing locations, it's also pulling anesthesia providers away from surgical hospitals. So as more and more providers leave to go to ASCs, it's further contributing to the number of providers at larger institutions and hospitals. One thing I think that gets overlooked a lot is the non-operating room anesthesia, or we call NORA. Not only are there more procedures on top of our normal OR surgical procedures happening, we have more complex procedures outside of the OR. We have sicker patients outside of the OR. And I think any anesthesia leader on this call can attest to the fact that out of OR sites tend to be harder to manage from a staffing standpoint. For example, you may need to staff an MRI under an anesthesia care team model on the other side of the hospital. You have to send one CRNA, and depending on the rules and regulations of your hospital, you have to have an anesthesiologist supervising that. Well, instead of that anesthesiologist being able to cover 3 to 4 rooms in the main OR, or whatever your setup is, now you've devoted 2 extra providers outside of the OR for a case and taking them out of the OR call pool. So not only are we being more in demand outside the OR, it is more difficult to staff. On top of that, non-operating room anesthesia tends to be at different hours than the main OR. It's not uncommon to have cardiologists wanting cardioversions in the middle of the day. It just so happens to always be at lunchtime for some reason, or interventional radiology or endoscopy, predicting those schedules and staffing for them incredibly hard. So, these 3 things are really contributing to increased demand. So we're short supply, we're needed more. I think everyone probably can deduce what that will lead to. But there's other factors involved that I wanted to go through. Administration, in addition to asking us why they're having trouble staffing, the ORs are also asking, why is it costing me for anesthesia? We have private groups. They're telling us that their cost of anesthesia is going up, their reimbursement's going down. Over the past several years, we've seen a decrease in reimbursement and collections for anesthesia services. It is putting a large crunch on healthcare systems, on private practices, on anesthesia staffing agencies, on locums, everywhere. So we're definitely seeing this. We continue to see it. It's hard to predict what this will be in the future, but as of now, this is a downward trend in reimbursement for anesthesia services. We're also seeing a very dynamic landscape as far as regulatory dictations as far as how anesthesia can be delivered state by state. As everyone knows, there's anesthesiologists, we have CRNAs, we have anesthesia assistants. This changing landscape is also affecting supply of anesthesia providers. There may be CRNAs located in one state that want to practice at a higher scope of practice and may leave to another state and thereby continuing to shake up the landscape. It's also leaving some hospital systems and administrators confused as to what is the best way to deliver anesthesia, the safest way to deliver anesthesia, and also the most cost-effective way to deliver anesthesia. And, you know, this is a confusing topic. You know, people may know that there's anesthesia assistants, may know there's CRNAs, know that physicians can do their own cases, but nobody's quite sure how to right-size that to a model that fits best for their case acuity, their patient safety, and their revenue cycle. So that is the fourth sticking point as far as creating this kind of unsteady environment in anesthesia services. So we talked about the challenges and the challenges leading to these calls we have with administrators, anesthesia leaders, surgical leaders within the hospital regarding what they're seeing as a real disruption in providing anesthesia services for the hospital or healthcare system. We wanted to go a little bit into what we're doing or what we're seeing as far as some remedies. And, you know, this is only a 45-minute talk. We don't have a lot of room for all the details, but we want to also convey what we're seeing within the market to help your system or hospital make decisions about anesthesia services. The first thing we're seeing, and we're seeing it also in most places across the country, is a rapidly dynamic changing compensation structure and market changes in anesthesia providers from AAs to CRNAs to physician anesthesiologists. And when we say it's changing rapidly, we really mean it. We've had market adjustments in some markets at least every 2 months for the last 6 months. We're in a large city in the northeast of the United States that have seen CRNA yearly wages increase from $50,000 to $60,000 per year. Once one competing hospital increases wages, we're seeing others in the marketplace react the same way. So this is very dynamic. It is continuing to change and probably will be for the foreseeable future. So with decreasing reimbursement, increasing costs of anesthesia services, more and more hospitals, healthcare systems, private practices are seeking more remuneration for anesthesia services. Right now, roughly 80% of anesthesia practices, private or employed, are currently receiving some kind of stipend or subsidy from a healthcare system. We were recently in a large system in California. At the market survey there, we learned that about 69% of California hospitals are subsidizing anesthesia services. We get asked a lot, how much is the normal for a subsidy or reimbursement? And this can be a very wide range. Can be a few $1,000s per provider to somewhere near $100,000 per provider. So very large range, but I think the take-home point is a lot of people are feeling this. it is on the rise as far as stipends or reimbursement for anesthesia services. Most people understand that anesthesia is the gas for the car as far as providing surgical services and increasing volume of surgical services, but they're increasingly becoming aware and worried about the cost of supplying those services. One thing we've definitely noticed as administrators and leaders within healthcare systems are seeing and noticing an increasing in anesthesia costs, especially during COVID. We have found that hospitals and leaders are looking more towards their anesthesia department for leadership and integration into the needs of the healthcare system. No longer acceptable to just provide great, safe patient care. With the increasing cost, we are definitely seeing a need and a want for leadership within anesthesia, leadership in growing centers of excellence, leadership in the daily OR operations. We believe it's essential for anesthesia leadership to be integrated into nursing and surgical leadership within a hospital, especially while we're in these times of being short-staffed. They need to be proactive with hospital leadership and nursing leadership for surgical scheduling, block scheduling, OR utilization, efficiencies within the OR. Anesthesia leaders need to be developing ERAS programs, surgical homes, and really participating in a broader perioperative scope of practice. Developing more of your pre-anesthesia testing, solidifying guidelines, standardizations of procedures, increasing regional anesthesia. All these things are things we do and may or may not have been noticed by administration, but these are things now the hospitals and healthcare systems are asking to be more involved to justify a higher stipend or subsidies to support the anesthesia department. Here's a chart for compensation from 2016 to 2020 for both anesthesiologists and CRNAs. I think Jeff and I are both very confident that the anesthesiologist compensation and likely the CRNA compensation after 2020 does not look like this. It is more likely going to be a higher upslope as far as average compensation. Like we discussed earlier, there is a shortage. It's a supply and demand game. There's very stiff competition within markets to make sure that surgical services continue uninterrupted or at least as little affected as they can by this anesthesia shortage, and they're willing to pay for that. So the market, again, is quickly adjusting. Compensation levels are rising for both groups. I apologize, we do not have a great amount of data on AAs, but we do have a very experienced knowledge of what's going on in the market right now with both anesthesiologists and CRNAs. So the cost of providing anesthesia is going up. And there's no doubt about it. So, it was a kind of doom and gloom, several slides. There's not enough anesthesia providers. They cost more. They're asking for more money. We understand there's some things we need from them as far as the integration into the healthcare system and management of surgical services. But we wanted to spend the next several minutes talking about some of the higher level strategies we're looking at to deal with a short supply of anesthesia providers so that we can continue to advise clients on how they keep their operating rooms running with as little disruption as possible. Of course, there's far more detail than can be discussed during this time, but we want to just bring you up to date from a very high level. So we're seeing many more institutions asking about how they can have an effective model to maximize the staffing they have and be as lower the cost of anesthesia through looking at different anesthesia care team models. Whether that's an all MD only group providing anesthesia, they may be interested in the anesthesia care team model involving CRNAs or anesthesia assistants, Or they may be a medical direction anesthesia care team model that is interested in talking to us about how they can switch to a medical supervision model. This is a very busy slide, and there's other permutations of this slide. But we wanted to give a little idea of the ratio of anesthesiologists and CRNA to what they may be from a reimbursement or billing standpoint. Every hospital is different. The case mix, the payer mix, the acuity of care of the patients, the surgical mix of patients, even the non-operating room anesthesia, all affects this. And there may not be one golden ticket for everyone in the whole United States to use because this is the best model. It's really a matter of analyzing data, case mixes, all the things that go into the operating room and deciding which model works best for your institution and which model pairs best with patient care to possibly lower the costs of providing anesthesia services. This, again, is not taking into account AAs, and that's also a possibility as well. And of course, I want to reiterate that patient safety and good patient care is paramount. So again, the acuity of your patients is important as well as lowering the cost of anesthesia services. This is a graph illustrating the change to more of an anesthesia care team model across the country. I don't think it's any mystery for the anesthesiologists or anesthesia providers on this call to know that the East Coast is predominantly, not predominantly, but been much more active in employing anesthesia care team models than the West Coast. We see that trend moving west and increasing in the East. So the ratio of nurse anesthetists to anesthesiologists is rising. There are more and more institutions that are choosing to adopt a anesthesia care team model. There's more and more institutions interested in learning about the ramifications of how they might change their anesthesia care team model. But this is happening. It's continuing to increase across the country. Finally, another piece of the puzzle is how do we staff our ORs intelligently? As an anesthesia leader and active leader and advisor, it's a tough nut to crack. We only have so many providers. We cannot produce providers with a snap of a thumb. We have healthcare systems that want to increase their surgical volume. For every surgical or procedural case that needs anesthesia, we have to have a provider. Because of this, we have to be smarter about how we align our anesthesia staffing, our use of PRNs, our use of part-times, our use of locums anesthesia providers to match intelligently what actually happens in our operating rooms. Everyone has a block schedule. We get that. But there's often a difference between the utilization of the ORs and what the block schedule says. So how we advise our clients is we take a look at their data and we look at probability charts of how many rooms you're running at a specific time of day on a specific day of the week. When do your rooms come down? How many people and providers do you need after 3 o'clock? How many do you need at noon? Are there enough providers for breaks? What does your overnight call look like? Do you need someone in-house or can someone be suffice from coming in from home? What are your normal hours of operation? And in this way, we can intelligently design staffing models that decrease the amount of downtime as well as decrease the amount of overtime or locums providers that you need to supply anesthesia services. Why are we going to staff 6 providers on a Tuesday when we only run 4 rooms at max? Why do we only have 4 providers scheduled on Wednesday when we usually run 6 rooms? And I think it's a really important point to this group that the block schedule does not always match utilization. And it's those after hours, overnight, overtime hours, asking physicians who are salaried to stay that are increasing cost and increasing burnout to your providers, making them look towards other jobs and other opportunities. So it's very important to match your staffing with what's actually going on in your OR and not guessing like we used to after a block schedule. So that's kind of a rundown of what we're seeing, why we're seeing it, some of the things we're doing as we advise our clients. I think there's a couple other points that are very important that I'm going to let Jeff speak to, namely recruitment and retention and other models of employment for anesthesia providers. So with that, I'll hand it back over to Jeff.
Thanks, Jason. I really appreciate that. I think before we get into a lot of the strategies to help recruitment and retention, one of the biggest issues is how do we maintain the financial viability of our anesthesia group, and how much reimbursement do we need from the payers to create a self-sustaining group. And what we've done is we've looked at this in a lot of markets. It varies by market, compensation, and some of the government pay and some of the other issues. But in a typical community hospital with an active OR, 24-hour coverage, an active OB service, covering endoscopy, cath lab, interventional radiology, it typically requires a blended unit of $70 a unit to make a financially sustaining anesthesia group without the need for a subsidy. And for those of you that might be unfamiliar with a blended unit, what that is the average unit reimbursement for an anesthesia unit by all the payers, government payers and commercial payers and managed care payers. So what's important for every organization to do is to really look carefully at their cost of anesthesia care, divide it by the number of anesthesia units being generated, and calculate what blended unit do you need for reimbursement. This is going to be important when you sit down with your payers for contract negotiations, and it's also important if you have a good relationship with some of the major employers in your market, schools, government agencies, maybe a large corporation, because if they're going to provide their employees with surgical care, they not only have to offer insurance, but they need to make sure the payers are paying us providers what it takes to attract and retain anesthesia providers. And what we've seen is getting down to the actual unit reimbursement is really important in these negotiations. I think now what I'd like to spend some time talking about are alternate models for hospitals or ASCs to contract with the anesthesia groups. 10 years ago, most of the anesthesia for hospitals out of academic medical centers was a relationship between a hospital and a private anesthesia group. And as anesthesia groups have faced challenges, I think what we're seeing is hospitals are considering different models for their anesthesia providers. Some hospitals are saying, if we have to subsidize anesthesia, should we just employ the anesthesia providers? What are the advantages of that model? What are some of the disadvantages of that model? And clearly, one of the advantages is it's an alignment of providers. If you have a large group of employed surgeons in primary care, there might be a real benefit in also having the employment of your anesthesia providers, so everybody is part of this larger multi-specialty group. It also provides an advantage in some cases for contracting, because what the organization can do is to make sure with the payers that anesthesia isn't being ignored and they're getting that blended unit up to where it needs to be. And what's important to understand is your government payers have a very low unit reimbursement for anesthesia. Medicaid could be in the teens, Medicare in the 20s or 30s. So that's saying in most markets, we really need the commercial payers to pay us $90, $100, $120 a unit to maintain financial viability. And having those discussions at a local level helps. Sometimes the problem with the anesthesia group is that the group just lacks strong management. And what employing the anesthesia providers allows you to do is to insert new management in the group who can deal with the real issues in today's world about providing anesthesia coverage and at the same time making sure that the group is viable. And it gives that new leadership the authority to address issues that maybe they didn't have when they were a private group. Some of the disadvantages of an employed group are that the management of an anesthesia group requires different practice management resources and skills than a primary care or a surgical group. So you need to make sure you either have those skills or get those skills to do it, particularly in terms of anesthesia reimbursement. And the other thing is going from a private group to an employed group is a real emotional issue for anesthesia providers. And some might feel that they no longer have a voice, they're not controlling their destiny, and that makes them unhappy, and some leave over this. So there's a lot of pluses, there's a lot of minuses. It really depends upon the political situation, the financial situation, and just the nature of your market. Another option clearly is to look at contracting with a national group, and there's a number of them. One of the advantages of these national groups is that they really have a depth of knowledge in terms of anesthesia, billing, recruitment, how you bring a group together that your local group may not have. They have a lot of resources to address issues, and they've seen almost everything. So that expertise is important. They also have very robust recruitment programs. They've developed deep relationships so that they have an array of AAs, CRNAs, and physicians, and that they can bring that recruitment expertise to your organization to fill in gaps. Anesthesia billing is complex. It's different than others, and there's a lot of disadvantages because you can't get the upfront payment. What the national groups typically are is very good at billing and collection, and some of them are also extremely good at managed care contracting because they have a broad understanding of the rates in markets across the country. Some disadvantages are that as a either publicly traded or privately held business, they need to make a margin, and they typically build in a margin of somewhere in the teens to 20%. That's money that's going outside of your market that could be spent increasing the compensation of your anesthesia providers. So you have to weigh if that's correct. Because of the margin, in some cases, there's been a compression of anesthesia compensation, and that's an issue. One of the biggest issues is when you have a national group, that local practice manager usually is part of a hierarchy. And when you talk about issues with that local practice manager, such as we're opening up new ORs, I need 5 more anesthesia sites covered today, that means that you're probably going to have 6 or 7 more anesthesia providers. Before they can make a commitment, they need to talk to their superiors. So it's a delayed decision-making process, and that can be frustrating to a hospital executive that's trying to make decisions fairly rapidly. So it's that layer of complexity that is important. So we've talked about some of the organizational issues. Jason's talked about the compensation issues, and paying anesthesia market compensation is a basic to making sure you're able to recruit and retain providers, but it's not enough. And there's certain characteristics that we see over and over and over again of groups that have a high retention rate, that are really attractive to new young anesthesia providers or even others looking to join. I think the first thing that we talked about is that you've got to have competitive compensation. That's a given. Anesthesiologists are not like pediatricians or primary care. Compensation is a big motivating factor. For CRNAs, the other big factor is allowing them to practice at the top of their license. They've developed these skills, they have confidence in their skills, and they want to function as independently as possible and use these skills, whether they're putting in blocks, doing epidurals or whatever. If you restrict their ability to function at the top of their license, you're going to restrict the number of CRNAs that are attracted to your organization. Anesthesia also wants to have a say in how their environment is run. So they're looking for organizations that have collaborative OR governance structures where anesthesia is at the table helping to guide and direct how perioperative services are. In anesthesia is a medical director that probably works with the director of surgical services at the hospital, running the board and running anesthesia in the OR on a daily basis. What they're also extremely interested in almost every location, is an anesthesia provider wants to feel valued and supportive, that they're not just a cog that makes the OR run. They're highly trained, skilled individuals, and they need to feel on a daily basis that they're appreciated for the sophisticated training they have and for the care that they're giving. We're also in an era where there's lots of conflicts with people's lives, and it's not like 20 years ago where every anesthesiologist was working every other weekend and taking call. There's a lot of anesthesia providers that need balance and flexible schedules. If you're going to attract them, you need to have some positions where there isn't call, where they might only work during the day, or they might only work 3 days a week. Some anesthesia providers want to just work weekends. We've got to look at flexible schedules that is appealing to a broad range of professionals with different interests. Because of the shortage of the anesthesia, we've got to make sure our ORs operate efficiency. There needs to be a verticalization of our schedules. We need to make sure that cases start on time, and we have the processes and staff to turn over cases quickly, because we need to get more output out of the time that we're running our ORs and our blocks. Out of OR coverage, as Jason talked about earlier, is a real complex part of the equation, and we need to manage how those are scheduled and integrate the scheduling of the out of OR locations with how we schedule ORs. Something that goes without saying is that there needs to be zero tolerance of inappropriate behavior by surgeons. It's no longer acceptable for a surgeon to scream and upset the providers in the room. There needs to be a rapid disciplinary process if that happens, and if a surgeon over time is counseled and doesn't change behavior. Organizations that want to keep their nursing staff, their anesthesia staff, just agree that this surgeon isn't going to work within our organization. I think the other thing that we need to do is we need to pay attention that we need to give all anesthesia providers, CRNAs and physicians, the opportunity to advance, both clinically, if they want to help medically direct our pre-anesthesia optimization, if they want leadership in being the liaison to important service lines, CV, orthopedics, obstetrics. We've got to give them opportunities to advance. So it's not just a job, so it's an opportunity to grow. Let's go. So I think in summary, what we're saying is that it's clear that the market is evolving. We've got to look at different solutions to how the market is evolving. And we feel that this is just part of a discussion that's going to be ongoing in the healthcare, perioperative and anesthesia field about how we make these adjustments. So before I turn it over to Alan for questions, I'd also like to remind people they can contact Beckers or send an email to me at jpeters@surgicaldirections.com. A number of people in the comments section have asked for hard copies of these slides, and we're happy to email it. Again, it's just reach out to Beckers or jpeters@surgicaldirections.com. Alan?
Fantastic. Thank you so much, Jeff and Jason, for that fantastic presentation today. So as Jeff said, we'll now begin today's question and answer session. Just a reminder, you can still submit any questions you have by typing them into the Q&A chat box you see on your screen. So let's jump into the first question that comes from an audience member is, we have an excellent anesthesia group clinically, but the group lacks leadership. What are the options to address the leadership void?
Sure, I'll take that one. It's a great question. I think as I kind of talked about, the need for leadership this present day in the current anesthesia market is critical. There's a lot of options there. Finding someone internally or externally is the obvious question, the obvious answer to that question. If there is leadership potential internally, there are several leadership courses that are given by the ASA or other organizations. I have seen organizations that have good leadership in other departments mentor an anesthesia leader. We as Surgical Directions have helped with mentorship of leaders as well within anesthesia departments. And, every institution, if they do not have leadership potential or a great anesthesia leader internally, can always look outside. That's extremely hard right now, given the current state of affairs in anesthesia, and that good, quality, effective leaders in anesthesia are fairly hard to come by and are definitely enticed to stay with the organization they are currently with. So, the short answer to kind of more complicated question than it is on the surface is look internally. If you have someone with the internal potential, find someone to mentor that candidate. Look towards sources like the ASA or other governing bodies for leadership courses, or look outside the institution for someone with leadership experience within anesthesia.
Got it. That makes sense. Thank you so much for running us through that, Jason. The next audience question we have is, our anesthesia group wants to cover an ASC in our market to help them financially. What are your thoughts on allowing the hospital's anesthesia group cover an ASC in the market?
Hi. So that is a very common occurrence. And from the anesthesia group's perspective, typically the reimbursement in an ASC is higher. They typically have a larger percentage of commercial patients, a much lower percentage of government patients. So the anesthesia group not only wants to cover it because there's higher reimbursement, it also helps with their call coverage because you have a larger group of anesthesia providers who can cover call. From the hospital's perspective, it really depends upon what their priority is. If the hospital views that the high quality of anesthesia group that they've recruited is part of their competitive advantage, that gives them the opportunity to attract surgeons, that provides a higher level of care, they're going to be very reluctant to allow that anesthesia group to go to an ASC. What the hospital might also be thinking is the anesthesia group is really part of our marketing or sales force, is they do a better job of meeting a surgeon or proceduralist needs. That helps to attract that surgeon to bring more cases to their organization, and they don't want that anesthesia provider to be indifferent whether they serve that surgeon's need at the hospital or an ASC. So it really depends upon what's driving the organization. Is it a sort of market growth, product differentiating factor, or is it a financial factor? And nobody can answer that question. It's got to be answered internally by the hospital in discussions with the anesthesia group.
Got it. That makes sense. Thank you, Jeff. Next question we have is, we are having a difficult time recruiting and retaining anesthesia providers and are losing good clinicians for better paying positions. What strategy should we consider to compete?
Sure. I think the most obvious answer to that is looking internally to make sure that your compensation package is competitive. Right? That's the most obvious answer, but I think Jeff really alluded to some of the other factors that go into play as far as anesthesiologist retention and recruitment. Sorry, I'm getting a lot of feedback here. I apologize. What we're seeing is, what I'm seeing personally around the country is the need for flexibility. But more than flexibility, what I'm seeing is predictability. So outside of compensation, vacation, which are the obvious, we're seeing more and more providers being looking for other jobs because of burnout at their local institution. The institution is not staffed correctly, or they have not filled their gaps with locums or part-time physicians or CRNAs or AAs. And what they're really looking for is a place that is going to have some predictability in their schedule, know that they have a window of time where they will be getting out and going home. There won't be a surprise missed dinner or missed soccer practice once a week. And I think all providers in healthcare are used to sometimes having to stay late. But what I'm seeing and what I'm hearing, in addition to the basic compensations, time off, is how can you tell me that I can tell my significant other what time I'm going to be home predictably? And if I can't, can we talk about ways that I could be compensated after that time? So burnout is a major factor, and I think anything an institution can do to mitigate that in the future is going to be just as important as the nuts and bolts of agreement as far as compensation and time off.
Next question.
Got it. Okay, fantastic. We've got one question come through from an audience member in reference to compensation. So what average physician compensation and CRNA compensation is assumed for the $70 per unit blended rate?
So again, it's market specific. The $70 rate is in one market. It might be a different rate in the other. In the market model that we looked at in calculating the $70 unit rate, it was physician compensation in the mid 400s, CRNA compensation in the neighborhood of 225 to 230. And there was another question somewhat related to that I saw in the chat box. Somebody wanted the formula for how you calculate the blended unit rate. So I'm going to go real slowly if you want to write this down. So the numerator is your total anesthesia cost. That would be your salary and benefit costs for all of your anesthesia providers. It would be your insurance cost. It would be your billing cost. So the total cost of sort of employing and managing the anesthesia group. That's the numerator. And the denominator is the total number of anesthesia units billed. And again, it's going to depend on the marketplace, but you can get the total number of anesthesia units billed from almost every anesthesia billing system. So that would be the type of information you would look at to look at the blended unit.
Thank you for walking us through that, Jeff. Let's jump into our next question. How do you have hospital/OR track non-OR procedures requiring anesthesia to calculate efficiency or productivity per room or anesthesia provider?
Sure, that's a great question. I think this question is outside of designating block and really kind of the real world what's happening, because I think any anesthesia provider on the phone can attest to the fact that most NORA, or a lot of NORA, I shouldn't say most, operates outside of block. So the way we run utilization data for NORA is we take as much block as we possibly can to pull from the EMR to designate or understand utilization the same way we do the main OR. For non-blocked NORA, it's extremely difficult to run utilization, right? I mean, you don't have a denominator in the equation to do that. So in institutions where I have some leadership, what we are doing actively, or we are trying to corral the NORA sites into blocks. We would typically ask, just for example, instead of IR doing cases sporadically during the week, we try and give them a block for their patients outside of emergencies on a Tuesday so that we can start reviewing and understanding that utilization. But it's impossible to measure utilization without a block scheduled. So the first step to understanding that is do your best to work with administration, nursing leadership, and the proceduralists to start setting some block for NORA, and not to have it ad hoc and whenever someone is available. And in that way, you can start understanding how to adjust out of OR utilization to get more predictable schedules.
Got it. Fantastic. Jeff and Jason, I'd like to just give you one more round of applause. Thank you so much for that excellent presentation today. And again, to the audience for those fantastic questions as well that came through. That is all the time we have for today. Fantastic presentation once again. On behalf of Becker's, I'd love to thank Surgical Directions for sponsoring today's webinar. Please do, to learn more about the content presented today, check out the resources section on your webinar console and fill out the post-webinar survey. Thank you so much for joining us today. We hope you have a great afternoon.
Thank you.